Good morning. My name is Aditya Nair and my today's topic is trigger finger. So what is trigger finger? Trigger finger is also known as stenosing tenosynovitis. That is, your fingers will be in flexed position. That is, they can go into flexion as well as extension, but the fingers remain in flexed position. They can passively extend, but active extension is somewhat of difficult, and it depends on the severity of how much difficult it is. So stenosing tenosynovitis is when there will be inflammation of the sheet that is covering the particular flexor tendon. Also, can the trigger finger can also be known as trigger thumb because it usually occurs in thumb. Also, it is the most common affected digit. Um, so let's go into the anatomy. So anatomy is these are the flexor tendon, and there are particular pulleys present inside your tendon. That pulleys make it easy, that is makes the movement easy, that is it allows the movement to occur smoothly. So what happens is when there will be inflammation of this tendon sheet, right? So this particular pulleys will get entrapped inside, and due to overuse of your finger, that is continuous flexion extension of your fingers, can lead to entrapment of the particular pulley while going into flexion, and while extending they get entrapped, and so the particular fingers remain in the flexed position. As you can see, there is the tendon nodule, you can see, which is inflamed, which is causing your entrapment inside the pulley, and you're not able to extend the finger. So this is the pathogenesis as well as the clinical findings. Causes are usually acquired as well as congenital. Acquired causes like idiopathic, no reason, like after postpartum, that is after pregnancy in females, it is commonly seen. Family history may also be present. There may be a trauma, or there may be like systemic diseases like rheumatoid arthritis or diabetes mellitus or hypothyroidism. In case of congenital, it usually affects the thumb. And as I said, there will be inflammation as well as the hypertrophy of the retinacular sheet, which leads to trigger finger, right? And which causes restricted motion of the flexor tendon to A1 pulley. And while here we have actually classified them into grades, that is grade 1 is there will be only pain as well as tenderness at the A1 pulley plus morning stiffness will be present. Grade 2 is the particular digits will be locked in flexion, and active extension is actually difficult, okay, and there will be pain also while trying to extend it. Grade 3 is there will be a palpable nodule present in the A1 pulley area. Palpable nodule will be present as well as locked position of the digits, but still passive extension is still possible. Okay, passive extension is still possible. And grade 4 is fixed flexion contraction. So the fingers will be in flexed position itself. You cannot even go for active as well as passive extension. So diagnosis is usually done clinically only. The patient will complain that they are able to go into flexion position, but after bending the fingers, they are unable to extend it, unable to straighten it out. They will say there will be snapping type of sound is coming from the fingers, as well as in case of grade 3 or grade 2, there will be tenderness as well as a palpable nodule will also be present around the A1 pulley area, and a catching type of sensation may also be felt, like catching sensation will also be present, and clicking or snapping sound may also be present, as well as the movement will be reduced and there will be increased pain. Medical treatment is steroid injections as well as surgical release. Steroid injections like corticosteroid injections can be given to reduce the pain, and corticosteroid injections are given only when the particular pain has been there since like 6 months. Less than 6 months, you don't give corticosteroid injections. You can give analgesics like NSAIDs to reduce pain, and conservative management can be done. Surgical release is they are releasing the particular flexor tendon sheet, that is the retinacular sheet, they are releasing it so that the particular inflammation will be relieved, and then it is kept after surgery it is kept in immobilization with splinting. Physiotherapy treatment, we have cryotherapy. Cold packs can be given in the for pain, And splinting can also be done, so that to reduced movements, for you can give rest to the particular finger, so gradually the inflammation will be relieved. Ultrasound can be given for tenderness around the area as well as for the nodule. Then stretching of the fingers can be done, that is the MTP, IP joints can be done, right? Flexion, stretching can also be done. Tendon gliding exercises, that is, you have to go for tendon gliding exercises so that there will be a smoothness will be present, and the particular inflammation will also be relieved. After somewhat the pain has reduced, you can go for tendon gliding exercises so that the surrounding muscles will be strengthened, that is lumbrical small muscles will be strengthened, as well as the A1 pulley can move smoothly through these exercises. As you can see, we have 4 steps, that is straight, hook fist, then you have to go somewhat up down, that is also a straight fist, then full fist, like this, full fist. This is the 4 areas. And here we can see also there is splinting, that is the fingers will be kept in complete extension, do not go for any flexion. Splinting is usually done in the acute phase to keep the fingers at rest. So that's it. Thank you. And these are my references. Pathology and Intervention in Musculoskeletal Rehabilitation by David J. Maggie, and Textbook of Orthopedics by John Ebenezer. Thank you.